Dobro večer, dobrodošli. Good evening. Tonight we will have a lecture by Emma Dowling, Care Beyond Crisis. And Emma is a sociologist and politologist currently based in Vienna. And she will talk about the care crisis. Care crisis is also the title of her book that it's very informative about the care crisis. Although it's dealing mostly with the care crisis in UK, I found it very relevant for our kind of situation because we can observe somehow we are maybe a few years behind processes in UK, but we are there, you know. And Emma, take the floor. The floor is yours, and please welcome Emma with applause.
Thanks very much, Davor, and thank you very much for the invitation. It's a real pleasure to be here with you in Rijeka and to speak to you about what is not such a joyful topic, actually, but nonetheless, I think it's one that brings us together to think about new and different ways of caring for one another in the future. I wanted to start really with a couple of questions. Namely, I was going to ask you, first of all, perhaps those of you here to put your hands up if you care for somebody. Are you currently caring for someone? So we have... What type of care? Good question. If you feel like you're caring for someone at the moment. And hands up if you are receiving care from someone at the moment. Also, quite a few hands. I can put my own hand up there as well. And is there anybody here who does paid care work? Okay, so we have a few people who are doing paid care work as well. What kind of paid care work are you doing?
I'm sorry, I was thinking getting paid.
Ah, okay, getting paid care work. No, doing paid care work, I was wondering. Okay, so not so many people here, but a couple who were doing paid care work. So the issue that I wanted to raise really was that care is something that somehow we're all of us involved with in some way, either giving care or receiving care. And I think at the moment, there are a lot of problems with giving and receiving care. And so I want to talk to you today about care crisis and what I understand by a care crisis. I want to talk about some of the ways in which we can see that this crisis that we have has sort of long-term structural causes, but also there are sort of ways in which this crisis is trying to be fixed in quite short-term ways that don't really solve this care crisis long-term. And then I want to kind of just dig a little bit deeper and ask, well, how do we have this situation where something that is so important, actually, to our lives seems to be constantly pushed to the margins, invisibilized, undervalued? What's going on there? Why is that the case? And then I'd like to sort of finish with an outlook of suggesting what we could actually do about this situation of crisis. And the questions that I asked you in the beginning about whether you're involved with care work or receive care work really pertain to how we think about what care is. And I'd like to invite you to hold three dimensions of care in your mind during the talk. Namely, on the one hand, care as all of those informal relations of care in the context of kinship, friendship, and community networks that we all rely on to maintain our lives and also our livelihoods. So much more the kind of informal context, family, community, friendship that we exist within. But there are also care needs that are specific to a physical or mental condition or stage in the life cycle that we move through in our lives that need to be met for someone to live well. And these can involve also more formal care relationships, often also professionalized care of someone who requires particularly assistance because of a physical or mental condition. At the same time, care and caring also has a kind of qualitative dimension to it, right? It is a kind of affective disposition. There is an understanding of being attentive to the needs of others, of relationality, of caring about someone. And often also it can be a kind of moral imperative as well, to care, the obligation to care about something or someone. So care also involves doing things with care, and we also know in the context of care work that doing care with or without caring can actually make quite a difference to the way in which people are cared for. So I'd like to begin with the care crisis, because this is a term that I worked with the book that I wrote, which is particularly about the context of the UK, and as Dava already said, perhaps other countries are a little further behind the developments in the UK, and hopefully you can learn how not to organise a care system. But also I think the care crisis is something that lots of different countries are experiencing because of some of the more broader structural conditions that we find ourselves in with our economy. But before I get on to those, I just want to say a few words about what I mean by a care crisis, because I think it's important when we talk about a care crisis to hold really two sides of this crisis in our minds at the same time. Namely, on the one hand, the inability of people to access the care that they need to live well, but also the increasingly difficult conditions under which care is provided, both paid and unpaid. So difficult working conditions, but also the difficult conditions within informal care relations. And that there are significant care inequalities as well. Not everybody experiences a care crisis in the same way. If you are more wealthy, then there are ways in which you can also buy care services that perhaps others cannot. And this is, of course, magnified in a global context. Overall, I think it's useful to think about a care crisis as a kind of exhaustion of societal care resources. So it's a way in which the resources that a society has to care are being depleted, are being exhausted, without much thought for these being replenished. So this is what I mean by a care crisis. And we can think also of different symptoms of care crisis. On the one hand, unmet care needs, so lack of facilities, long waiting lists, high cost, and this can be in the context of childcare, for example, lack of nursery schools or preschool education facilities, but also in the context of eldercare and healthcare and social care, things like long waiting lists for a place in a care home. I was reading about Croatia in the last couple of days, a report that was talking about how some municipalities have very few kindergartens, but also, or even no kindergartens at all, and also when it comes to eldercare, there are not enough care homes, and there are long waiting lists for people for care homes. This is also something that in Britain, in the context that I researched, also people are facing these kinds of situations. So parts of the UK, for example, one charity even talks about there being sort of care deserts for elder care. There aren't any care homes because of the way in which the system has developed, that I'll get onto in a moment. But also a crisis in informal care, so people caring for their children, but also caring for relatives, older relatives perhaps, or relatives who might have a chronic condition for which they require help or assistance. And here we see a lot of overburdening of informal carers, conflicting demands on time, but also lack of time, we were talking about it earlier, for self-care and for perhaps tending to one's own needs. This is, I think, an issue in lots of different places, and also something that is often quite invisible. Perhaps it's more visible with childcare and the sort of conflicting demands of trying to manage childcare and also working. But often with elder care, or where family members, usually it's female family members, are caring for relatives, this is something that's actually quite invisible a lot of the time. But people are under a lot of stress trying to manage these situations. The other area where we see symptoms of crisis is paid care work, where we have, in all different contexts and countries, poor working conditions, high sickness rates, high staff turnover, and acute staff shortages. So, for example, in Austria, where I live at the moment, there was a study done after the pandemic where 45% of healthcare staff admitted to regularly thinking about leaving their jobs just because of the level of stress that they were facing and the problems of always having to compensate for staff shortages. In Germany, there was a whole new portmanteau term coined, Flexit, they called it, which is a portmanteau of care and exit, with which the people were trying to describe the situation in the healthcare sector with so many staff leaving. And often, actually, where pay is an issue, but also simply the conditions of work are the most important issue that often workers say, and particularly, actually, care workers talking about the lack of time for the caring aspects of their job. So the relational, emotional aspects of the job are the first thing to go and fall by the wayside under these conditions of acute stress. Another example in Britain is in home care, for example. Home care, where carers are visiting people in their own homes and providing care for them, where home care visits are being reduced to 15, and the unions are also reporting sometimes 5 minutes to provide important care for people in their own homes. And this is, of course, also quite an impossible situation, or travel time not being paid for because it's not considered to be part of what is the care work being done, which seems to be a little bit oxymoronic if you think about the very definition of home care is that you're traveling from home to home in order to provide care. So it doesn't really seem to make sense. But you see, we have these different symptoms of care crisis, and even though there's a difference in different countries, there's a slide bit missing there. But what I wanted that slide bit that's missing to say is that even though there are differences in different countries, it seems that there is something very similar going on in these different countries, namely that either where there are problems and where there's shortages, it's either the market steps in as a solution, so commodification of care services, or the family. Right? So the family is then the port of call for care. So this is then daughters-in-law, mothers, but also other family members who are called upon to provide care. Gender is, of course, an important issue when we come to the topic of care. And there are a number of issues around the ways in which the care crisis intersects with gender. First of all, with regard to unpaid care work, globally women perform 75%, so that's 3/4 of all unpaid care work. And on average, women perform 3 times more care work a day than men. So that's like 4.5 hours versus 1.5 hours. So we see these kind of inequalities. But also in the paid care sector, so healthcare, social work, childcare, education. These are all areas that have quite a high female component of the workforce. Globally, 19.3% of female employment is in care work, and in comparison, 6.6% of male employment. So we see here also these gender differences. In the literature, in the academic literature, there is a term coined called care penalty, where we see systematically for women in particular a loss of earnings due to caring responsibilities, but also low earnings and low job quality because women are often working in the low-paid care sector or informally in people's homes or in a self-employed capacity, which means often they have reduced social security payments, but also because of caring responsibilities, they are unavailable for jobs that demand long or irregular hours. And all in all, we know care has a very low status. It's not considered to be particularly skilled work, and often, of course, it is associated with women, something that women do naturally, and because it is sort of part of their social role. But not only that, we also see that that workers with less power in the labour market are employed in the care sector. So also here an intersection with migrant labour and the racialisation of the care workforce. Certainly in Britain, this is a huge issue where we see a lot of people, migrant workers working in the care sector because of the ways in which the labour market gives different levels of bargaining power to different constituencies. And of course, also one of the ways in which countries try to solve their care crisis is by bringing in migrant care workers. We're also, though, in the context of these inequalities, seeing some shifts here. But these shifts are quite interesting to look at. On the one hand, there's research that shows us that often men are now more involved, for example, with childcare or also with other forms of caring, but that often it is nonetheless still women in the household who sort of carry the responsibility and what people term the mental load for the situation. Also, wealthier households are able to buy their way out, really, of caring responsibilities by bringing in care workers to take over childcare, also housework, and caring for relatives. So overall, because these are often, of course, other women who come in to do these jobs, often also migrant women, that there is no transformation, really, of a sort of social gender division of labour, but there are these shifts that are happening, right? So what has caused all this? Why do we have this growing care crisis? To a certain extent, we could argue that care has always somehow been in crisis, and particularly also that care has, for a long time, had very little value or is very invisible. But there are sort of moments in the history of capitalism. I'm going to not talk about the history of humankind, but particularly a sort of period of capitalism, where there have been arrangements that have been more stable than they are now. Right? And so what we're seeing now is a confluence of issues coming together which are really pushing on care, both paid and unpaid, that are causing a deeper and more urgent crisis. And one of these is rising care needs due to demographic changes. So an aging societies, people are living longer and therefore also requiring not only pensions but also care. Right? At the same time, there are fewer in the younger generation to actually provide that care, or also the productivity for those pensions. So we have rising care needs, particularly with regard to eldercare. But we also have, at the same time, it's like the crisis is sort of being pulled in two directions, or care is being pulled in two directions, because we're having rising needs at the same time while the resources for care are also diminishing. So on the one hand, a diminished availability of unpaid care. This is again different in different countries, but there is on the whole a tendency for greater female labour market participation over the last 30 years, such that the sort of role of women as carers in the home is put under pressure. Women are not available in the same way as a resource in the home. Whether or not we agree that should be the case is a different matter, but certainly on this kind of structural level, this resource is not available in the same way. And also, of course, double burden of having to work and care. The squeeze on time is also an issue. We have a situation where more and more time needs to be spent doing waged work in order to make ends meet. We have also a situation of wage stagnation, such that there is a primacy of waged work coupled with this wage stagnation, which means that more time has to be spent doing wage work, which squeezes the time on unpaid care work. And all in all, we see in different countries, again, cuts to public services. In the UK, this has been very dramatic after 2008, but also in other countries, and I know also in Croatia, you have experienced cuts and austerity measures as well, where we see a sort of tendency towards welfare state retrenchment. So the public services are being cut, but also social security being reduced. All the while, the solution of the market is also being brought in more and more. So privatization of care services, marketization of care services, commodification of care. And the issue here, and I'm going to talk about this a little bit more in a moment, is that where this happens, not only does this result in greater unequal access to care, because of course those with the money to buy these services can access them, others cannot, but also that the marketization of care leads to a situation in which the resources that are actually required to provide care are sort of extracted out through the need to generate profits and returns for shareholders, etc. But I'll talk more about that in a moment. But it's another way that we're seeing a squeeze on care. And undermining indeed, but also underlining this is the greater individualization. So the politics around this is of personal responsibility. It's your responsibility to care for you and yours, right? So famously in the UK, Margaret Thatcher, there is no such thing as society, but what she went on to say also, which is not quoted so often, is there are people and their families, right? So there is here this understanding of the responsibility being for you and your own. This is where my differences between the different countries were. So, I said it earlier, but I can only emphasize it again, that even though there are differences, and I think I could probably we could do a whole workshop on talking about what are the differences between Croatia, Austria and Germany, the UK, that there are different regimes, but there are, I think, nonetheless, these structural developments that pertain to all of these countries. And like I said already, this kind of double privatization or twofold privatization of the market and the family being the go-to, really, in terms of dealing with the care crisis and offering kind of fixes or short-term fixes for care. And what I mean by these short-term fixes for care or care fixes is that what we see in this context of crisis is attempts by governments, but also by individuals themselves, perhaps, to address this crisis situation by compensatory measures of some kind. So these can somehow offer an inadequate but somehow a little bit stable situation in the short term. Or we also see that the area of care is also an area where capital and finance are looking in order to solve their problems of looking for new markets and possibilities for accumulation as well. So looking for a kind of fix in this area of care. Another point here in terms of care fix is technology. Right? The technology also as a care fix. And I want to talk about these three in turn. So let me start off with a kind of austerity care fix, and this is perhaps one that is the most obvious, or perhaps also the most known to you, or something you probably have also experienced in some ways yourself here, where we see in the context of austerity and cuts, either to social security or also to public services, is that there's a kind of offloading of care onto families and often women in these families, but also to the voluntary sector, so volunteers, or also ways in which, because of cuts, staff that are working in these areas do more overtime, or they try and squeeze more work into less time. These are sort of ways in which compensatory measures are sought to deal with this situation of austerity. So in the area of social security in the UK, for example, what we've seen are cuts to spending, where in particular also there have been reforms to eligibility. Right, and more means testing, so actually less people can access the care that they need if they are unwell or older, because the stricter interpretation of who is eligible and who is not. In the area of public services, services are stopped or they're stretched in some way, that work is intensified for the staff that are working there. In the UK also, after 2008, there was a massive proliferation of food banks because of increased poverty that people were experiencing. And these food banks are all run by volunteers. And the tragic situation also was that increasingly these food banks have become institutionalized, where also people who are receiving benefits can then also receive are also told to go to these food banks as a way of compensating for their situation. So they sort of become part of the welfare regime, even though they're fully run by volunteers. And, of course, a situation that shouldn't be there in the first place. With households, there is a push towards offloading the work onto people in the home, or forcing people to buy in domestic services like nannies or cleaners and things like that, and calling on the family to care. Huge rise in the importance of grandparents and grandmothers, also in caring for children, siblings as well. In Britain, I wanted to raise this because I think this is an example that is particularly pernicious. What also we've seen after 2008 is a regressive alteration of the tax base. So all in all, actually, I think it's like 2% between 2009 and 2020. There's more even spent on some areas of welfare, but the money for this is being taken from a different segment of the population because of the way that the tax base is changed, so a greater increase on value-added tax, which is a big issue for people on low income because it raises their cost of living, but also lowering corporation taxes, changing the tax breaks for people. And so here we see actually that the poorer people are, the more they're actually paying for the crisis, not less paying for the crisis. So this kind of regressive alteration of the tax base. In fact, there were studies by human rights organizations that pointed out that in Britain, even if you agreed with austerity, even if you agreed the cuts were necessary for the economy, it was not necessarily to cut in the way that was cut, because this affected people with low income, but also people with disabilities, and people also racialized communities, and actually all groups and communities that were not the ones that caused the crisis in the first place, but also were the ones who could least afford to actually pay for the crisis. So austerity as a kind of care fix here that offloads care. The second care fix is what I've called here a financial care fix. Now, again, turning to Britain as my example and my kind of springboard into the issue, in Britain since the 1980s, there have been considerable efforts to marketise and privatise care. All kinds of care, from childcare to social care to eldercare, also healthcare. And this has been done in particular by a series of reforms that made the local council, so the local council is responsible for a lot of care services, put the local councils in the position of being what they were called market makers and market shapers. Right? And they do this through being the ones who commission private providers to buy, so they buy services from private providers that then provide these services, or also they give out cash payments to people so that they can buy services, so personal budgets, for example, what's called cash for care. And we've seen increasingly then a privatization of care homes, but also of home care, such that today in Britain, less than 7% of care services are in the hands of the public. And we've had a massive increase, not just of private non-profit, but private for-profit providers. And here we have in the beginning, in a lot of instances, these were perhaps small businesses that were not so interested in making a big profit. They were owner-run businesses, care homes, but with time they got bought up by bigger corporations, particularly also because investing in infrastructures or investing in the homes can be quite difficult to do because you need quite big financial resources. And so these chains were created through buying up the smaller care homes, such that today we have a situation where there are large chains operating lots and lots of care homes in the UK. And one of the issues there, of course, is the orientation to profit and shareholder value. That's one issue which pushes wages down, which worsens working conditions because fewer staff are employed. And here we see a situation where trying to kind of pull out profit from these care homes happens at the expense of care workers and the quality of care. That's one issue. And the other is that we also have private equity and other kinds of financial engineering entering the sector as well. So about a quarter of the UK care sector, there are private equity businesses, and this is a model that creates a lot of problems because what happens is companies borrow money and buy up the care homes, but the money that's borrowed is loaded as debt onto the care home business. And then that care home has to operate in such a way that they can pay back that debt and interest. Right? So it's really writing in this issue of having to operate at a level where you're making enough money to satisfy this situation. Another issue that happens is a separation of the real estate of the care home and the operative element of the company. And so you have a situation then where the operative element of the company has to, so that's like actually providing the care in the home, that they have to run the business in a way that they pay rent then to this other business. And of course, in a situation of rising rents, this creates problems. Sometimes these business entities are part of a larger corporate structure, so it's like transfer payments within the same corporation. Sometimes they're separate real estate investment trusts, for example. And there's a quite complex structure now, also a complex structure of corporations that it's very difficult to see inside them and what's happening and where money is going. But there has been quite some research done now that shows that roughly about 10% of the financial resources in the sector are leaving, sort of leaking out of the sector for shareholder dividends, management fees, property fees, tax avoidance, these sorts of things. So we're seeing here a situation which is actually publicly not so well known, where there is actually, through these sort of financial engineering tactics, wealth being extracted from the sector. And because care is not really something where you can do much to increase productivity, right? You can't really care for an endlessly more amount of people in less time. You can't improve the labor process in the same way as when you're maybe producing cars or washing machines, right? Because it's a very labor-intensive, it's a very time-intensive activity. So the idea that you can somehow restructure these care homes to be more productive and to be more profitable is also a kind of anathema, right? It doesn't really work. And so what happens is working conditions, wages, staff, quality of care, this is actually where then the deterioration happens in order to keep these business models afloat. And in fact, they don't keep afloat a lot of the time. There's also a lot of insolvency because it doesn't work, or there are all sorts of financial engineering going on that lead to these insolvencies, and of course economic downturn in the sort of more broader context of global financial markets. These sorts of things then also play a role because these businesses are all inserted into these structures and systems. So we've had lots of reports of insolvency, actually, which leads to instability. What happens when a care home closes? What happens to the people who are in the care home? And these are huge issues. But also, if it's not profitable, then these businesses leave and do something else and find something else to invest their money in. So it's also very unstable, right? And after the pandemic, this is also something that we saw. And it's not only something that is happening in the UK. Also, there's research now on Germany, France, and Austria, that there are developments in these directions here. And I also read that in Croatia, there are also developments in this direction as well. Not private equity, but certainly private for-profit homes. So there's a whole complex here about what happens when you introduce a logic of profit into this context, because precisely what I talked about already, we see so much then a kind of pseudo-rationalization of this of care work in order to render it more productive. But it's not only that, it's also precarious work and semi-informalization of care through commodification. So care as a part of an expanding gig economy. Personal services, personal and household services is one of the fastest growing sectors in the European Union behind digital technologies. Because of greater female labor market participation, because of aging, there is a real need also for these domestic services, and this is an area of expansion. Lots of digital platforms also expanding into these areas here. But, of course, the home is something that is not very easy to manage quality, to have quality controls. And we know also with 24-hour care, live-in carers, that's a situation where there are often quite untenable working conditions and also precarious working conditions. And as you will know, also here in Croatia, cross-border work, where care workers are going for 2 weeks to work in someone's home and then coming back to their country of origin, and the conditions are often not tenable. So here, this whole area, I think, is also something that we need to hold in our minds as an aspect that is part of this commodification as well. It's not the big profit-making, but it's this area of precarious work and semi-informalization, which also plays a role. The final carefix I want to talk about is technology, because this is also something that really is quite a big issue at the moment. There's at the moment, call after call coming out for research into the role of artificial intelligence in solving the care crisis. Not quite put like that, but it is put in terms of dealing with staff shortages in the care sector, and the hopes that somehow artificial intelligence and other kinds of digital technologies can assist with the situation in the care sector. And this is either posited as, on the whole, relieving a lot of the pressures in the sector, or also freeing up the time of care workers to focus more on direct care as opposed to something else. But I want to talk more about it, because I think it's very, it's interesting what's happening here, because I think it's not a case of technology is all bad or technology is going to save us, but I think it's an issue of understanding what kinds of problems are being identified and who's making the decisions about how these problems are dealt with. So quite broadly with care, we have I think 3 different areas to think about. One is information and communication technologies that play a role in the context of care. So one of them that will be quite obvious to you is telemedicine, right? So you speak to someone over the internet. This became quite big also in the pandemic, but also things like more digital documentation, so that healthcare workers and others can access documents and information about patients and can share them better, these sorts of things. Another area is assistive technology for people with particular conditions, to enable them to live more independently, also for people to be able to stay at home longer in their own homes, but also things like assistive technology in care homes, robots in care homes as well. And machine learning is, I think, another area where there's lots of hope that machine learning can be used to perhaps predict situations and predict when someone is going to need a particular kind of care, but also in diagnostics in particular, so more in healthcare rather than care as such. Two things that I want to say about technology and the way that it works I think are important here. One is thinking about this relationship between humans and technology, or the labor processes and technology. Namely, one is that when a machine takes on a task, it doesn't simply do the same thing that a human did beforehand. Larry Lohmann, I think, is very good on this and points this out. But the nature and even the meaning of tasks are transformed, and also new tasks are created in the process. So it's not so simple to just think, okay, the machine then does something that the human did beforehand. It's a much more complex process. And the other thing is also that the data-driven nature of a lot of the technological developments requires that these human activities are broken down and interpreted in terms of what can be quantified and measured. And so I think that's also something for us to think about, and what that does. So, quite crudely, are robots then gonna solve the care crisis? And you can probably think and tell from the way I've been speaking that I don't think robots are going to solve the care crisis, but let's look a little bit closer at the issue. So far, there's a very uneven distribution of technological developments in the area of health and social care. So there's lots of promise about what is going to happen, or what can happen already. But when we look to the actual implementation, it's very, very uneven. And that's because there are a number of areas of tension, actually, when it comes to care. And one of these is financial feasibility. Right? So what is the expenditure of investing in certain technologies versus the cost reduction? Right? So is this actually something that will reduce costs, or is this an investment that actually is linked to a greater expenditure? Another issue is workload and skills. So, for example, things like digital documentation that is introduced in the context of care. There's quite a bit of research that shows that this is something that actually increases care workers' workloads rather than decreasing their workloads. So here, there's a question then whether it's really relief or whether it's an increase of workload. But also the idea that time is freed up for direct care, I think, is an interesting idea. There's a book that recently came out by James Wright. It's called Robots Won't Save Japan. It's an ethnography on the use of robots in eldercare in Japanese care homes. And James Wright also points out that a lot of the time, or where some of these robots are introduced, the ways in which they are introduced means that actually they're not freeing up time for direct care because the machines have to be taken care of. They have to somehow be dealt with, but also that they don't really do what they promise to do. So if you have Pepper, for example, the robot that can show someone the way in a care home or in a hospital, but also can be used for like exercises for dementia or some sort of entertainment, that is something that actually means that the care workers don't have to think about doing these things themselves, so it's a kind of de-skilling, but also that it's quite kitsch, right, in a way that it doesn't really appeal to people. And you could say, well, maybe that's just an issue that we haven't got there yet. You know, maybe we need more sophisticated machines. But I think it shows what some of these issues are. Or also that if you've got to wheel this robot from room to room, that also takes time. So it's not so easy, actually, to just say these robots are going to help, or that they're going to somehow alleviate and free up time for direct care, because that's also something that is an issue. This idea that care is simply just a bundle of tasks that can be just split up and reallocated to machines or different human beings also misses the point of how care work is actually not just a complex activity, but it's also quite integrated. So you might be helping someone with their physical needs, dressing or administering medication or helping them with eating. And while you're doing that, you're also having a conversation where you might also be assessing their mental state or their particular needs. Right? And these things are actually happening at the same time. They're integrated with one another in a way that you can't just sort of split them out very, very easily, or it's a sort of misunderstanding of how care work functions. Or also the more intuitive aspects of care work as well are also not easy to simply automate or give to a machine. So I think it's also understanding those complexities and the integrated nature of care. Another aspect here is assistive technologies that are supposed to support people in their own homes. So machines that will bring you things in your house if you have reduced mobility, or technologies that connect people in their homes to, say, relatives who live elsewhere. And these sorts of things can be all very well, but they don't deal with the fact that we have, say, a loneliness problem of people spending too much time on their own. These technologies are not going to deal with those sorts of issues. And so again, sort of taking a broader picture here is at stake. And of course, a lot of technology that's implemented is used to reduce the autonomy of care workers, to speed up work, to survey workers as well. So research, for example, in home care in the UK looked at the ways in which the sort of digital system of documentation also meant that home care workers had to show when they had contact time and when they didn't have contact time, and this was also digitally documented, which means they were much more under pressure to perform certain tasks in this reduced time that they had for contact with someone, and then travel time and other things then not being part of that. And one of the issues that was raised here also was that care workers were finding that they couldn't actually do everything in this contact time, and so they were actually clocking out in order to stay a little bit longer to complete the task or to have a conversation with someone, and that this again was sort of extending the work time, but also was a way of trying to deal with this surveillance also in this context. So there are quite a number of issues that, again, I think we could do a whole workshop on technology and care, but just to sort of summarize what's at stake here, I've tried to put these issues out there. All in all, I think there is really an issue also about realization. So we have advances in research on the one hand, but then also the implementation in practice is much more complex. And I think also here, differentiating, say, between healthcare and social care also shows us where some of the advances in current technology are perhaps more helpful, say, with diagnostics than with something like social care, where it is more complicated. So not lumping everything in together, I think, is also important. So let me start to come to a close then, because I've already been speaking for some time. Bringing this all together then, what I've wanted to show you is that in this crisis context, we have a series of mechanisms for seeking to fix this crisis in ways that seem to devalue care even more. One of these mechanisms is how there are kind of new boundaries drawn between what's paid and what's unpaid, or what counts as work time and what doesn't count as work time, what counts as an essential task that definitely needs to be done, or more additional things that can happen if there's time to. And all in all, there's a kind of externalization of caring, in particular, along a kind of chain of subordinate, underpaid, and unpaid activities. So where, for example, in home care previously, a home carer might have done tasks like shopping and preparing food and these sorts of things. Now they do the very bare minimum of medical tasks because that's all that can be done. Those other tasks get relegated perhaps to a family member or to a volunteer or to a neighbor or to no one at all. And so you see this kind of cascade really of externalization, or in care homes, volunteers coming in, or in hospitals to take on tasks that, like reading to someone or bringing them a cup of tea or having a conversation with them, and these sorts of things. And so there are real kind of tensions also around the ways in which deprofessionalization happens, and the ways in which reforms also often promise a kind of improvement, but where the logic of cost saving is so strong, when we look closer, we see that then these are not always improvements, and particularly where stark boundaries then are drawn between what is higher status care work and lower status care work, or other kinds of work. So I think also here a lot of the time, or a good example is the difference, say, between qualified nursing and more assistive care roles, or live-in care in the home. And this whole kind of dynamic really relies the whole time on unpaid goodwill, commitment, a sense of responsibility of those involved to keep the system going against the odds, right? So that's really the resource that's being drawn on all of the time in order to function under these very, very difficult conditions. So we can ask, why is it that something that's so important, I think this is really a question that came to the fore also in the context of the pandemic, right, where there was such a spotlight also shone on these areas, and we saw this kind of paradox came to the fore also in this notion of essential workers, like who's an essential worker, and what are the conditions under which these essential workers are working. And we can ask, why then is something that's so important, so undervalued, and being done under such stresses and strains, or completely unpaid and invisible and not recognized? And one answer to this is that we have in a capitalist economy this separation between the productive economy and this reproductive sphere, where all of the work gets done to make available even labor power for the economy. So the feminist theory lens here of social reproduction and this separation between what is productive and what is reproductive, and what is this whole sphere that is so important to creating the conditions for any economy to, any capitalist economy to function, but that is sort of always either kept invisible or not acknowledged, and certainly not seen in terms of an area that needs resources and needs to be replenished, precisely because all of this care is, of course, a cost. And this cost needs to be kept as low as possible in the logic here of a capitalist economy. So all in all, we see that care has to continuously be made compatible with the demands of accumulation, so either indirectly by providing services in a way that allows for capital accumulation to function, so having a level of social cohesion that still allows for accumulation, so that not everything completely breaks down. But of course, the more that is stabilized and functions better, the more that increases cost in this logic. The other part of this is rendering this directly productive for capital accumulation. So huge interest in marketizing these areas, huge interest in investing in these areas because of the promise here of being able to make money, particularly also with regard to demographic changes. But that, of course, is extracting resources and extracting resources needed. So we have these real contradictions baked in to this system, and I think with the kind of neoliberal developments that we've seen, this is coming more and more to a head. But it also shows us, of course, that there's a politics here, and that the standards of care in any society are profoundly political. And that's why, and that's our entry point, I think, also, to think about what to do about it, right? So how do we remedy the crisis, but also how do we escape these continuous care fixes that seem to be always happening? Now, my proposal would be we have to really transform the conditions for caring, right? So it's not a case of simply calling on us all to care more, right? Because that would really feed into precisely this idea that we simply just all chip in and do what we can in order to remedy this situation without really dealing with these structural conditions that are leading to these problems. So I have a set of proposals that I want to finish with. And the first of these is that we really need to think about in terms of care for all. And to me, the most striking thing about this is that the idea that if everybody cares for themselves, then everybody is cared for, just simply is absurd. Like it's just not true. So this idea that sort of looking after yourself and your own will lead to a situation where everyone is cared for, just particularly stark when we look at care, precisely because everybody needs care, whether they're wealthy or not, but not everybody's care needs are the same. And our care needs are also not the same throughout our lives. And so here we really need a different understanding than one that simply focuses on the individual. The other thing is we really need to truly value care, and this is actually more controversial than it seems at first sight, because what we have to do is allocate more resources to this area, right? We need more time, more money, more societal capacities allocated to care. But part of that, of course, is dismantling this apparatus of financial extraction that is being constructed around care. So now I like that image, really, of thinking about it as this kind of apparatus of extraction that's been sort of built around it, and we have to dismantle it. Right? We have to do things in a different way. Caring for the carers means secure employment condition, recognition of trade unions and collective bargaining, precisely because we are talking here also about a politics of care in which the recognition of these collective negotiations around conditions are really important. But at the same time, it's not simply about improving the public system of institutionalized solidarity, we can say, even though that's very important. And it's not simply about professional and paid care. It's also about the relations that we have with one another that are not part of that professional care. It's simply also because I don't think paying for all care is really as such the solution, or professionalizing all care work. We also have to think about the ways that we live and care for one another in our informal context. So having time to care, but also time free from care. And I think also this is also something that's often forgotten, and this is also an important point about the feminist movement, is to say that their care is really important, but so are other things as well. We need to redistribute care work in different ways. And think about caring beyond the family, the nation, in ways that common these caring relations. And it's easily said, but then the question is, okay, what does that look like in practice? And maybe that's something we can talk about. And I think interesting things are happening around attempts and ways of thinking about how to reclaim care, and how it's not simply about reinstitutionalizing or institutionalizing centralized top-down institutions, but also thinking about what innovative new ways can we organize care that's not commercial experimentation, but that is thinking about how we live together, but also how there might be new kinds of municipal projects or public commons partnerships. In England, the unions are also, there are unions that have a strong campaign for insourcing, so bringing services back in-house, but also thinking about how maybe home care can be organized differently if also neighborhoods are built differently and function differently. And care is, again, more integrated into people's everyday lives. So I think there's a lot of scope here for thinking about how we build different kinds of solidarity, but it has to be, I think, underscored by an understanding also of public systems with redistributive effects, of building infrastructures that really institutionalize solidarity, so that it's not simply something that we do also out of our own volition, but that we really have a situation in which everybody can access the care that they need. Thank you very much.